Good morning, Dr. Smith. For my case presentation on teaching rounds today, I've put together a comprehensive explainer of an admission we received overnight. We are evaluating a really classic presentation of acute cholangitis. This is a critical physiological cascade where a highly localized biliary obstruction rapidly evolves into a deeply systemic, life-threatening sepsis. We are going to trace this patient's clinical trajectory right from the initial mechanical insult through the subsequent multi-organ failure and really detail the exact criteria that dictate our immediate resuscitation and mechanical decompression strategies. So, to truly understand the sheer velocity of this disease process and the absolute necessity for urgent mechanical intervention, we'll walk through the clinical course of a 68-year-old gentleman who presented to our emergency department. The central physiological question we have to answer here is this: how does an occlusion barely the size of a small pebble transform a localized ductal system into a high-pressure conduit for overwhelming bacteremia and endotoxemia? And why does this mandate that we bypass standard antibiotic protocols and go straight for immediate source control? Let's look at the patient. He's a 68-year-old man with a known history of type 2 diabetes and hypertension. He's had no prior abdominal surgeries and no prior biliary stents. However, asymptomatic gallstones were actually noted on his imaging about 2 years ago. On day 1 of his current illness, he developed a right upper quadrant ache right after dinner, which then progressed to rigors overnight. By day 2, he started noticing tea-colored urine, pale stools, and diffuse pruritus. Today, his daughter found him warm, deeply yellow, and newly slow to answer questions, which prompted the ED visit. On presentation, his temperature was 39.2 degrees Celsius, heart rate 116, blood pressure 98/56. His physical exam revealed prominently icteric sclera and right upper quadrant tenderness, though noticeably without rigid guarding, and a negative Murphy sign. Mentally, he was oriented to person but noticeably slowed down. Looking at the labs, his white count was 18.4 with a left shift. Total bilirubin was 6.8 with a direct of 5.1. Alkaline phosphatase was 480. His creatinine was 1.9 from a known baseline of 1, and his lactate was 3.1. A bedside ultrasound showed an 11 millimetre common bile duct with a visible obstructing stone, alongside a completely normal thin gallbladder wall. Now, to address the fundamental physiological findings here, his soft blood pressure of 98/56, paired with that compensatory tachycardia of 116, is the classic hemodynamic signature of early distributive shock. The profound systemic vasodilation from early endotoxemia is dropping his systemic vascular resistance, and his heart is just tenuously attempting to maintain cardiac output. Also, his unimpressive abdominal exam lacking true peritonitis is totally expected here. The biliary tree relies on visceral, not somatic, parietal peritoneal innervation, so distension of the common bile duct produces a deep, poorly localized visceral ache, which sharply distinguishes this pathology from the localized somatic peritoneal irritation you'd see in, say, a perforated viscus or severe acute cholecystitis. Moving into the pathophysiology of why he's deteriorating, acute cholangitis has to be understood fundamentally as a closed-space infection. You need two distinct pathologies happening at the exact same time. First, you have a complete or near-complete cessation of bile flow, which creates stasis just proximal to an obstruction. Second, that stagnant fluid becomes infected, allowing bacterial colonies to just multiply exponentially within a fixed, non-expandable anatomical space. This isn't just an inflammatory process like cholecystitis. The entire biliary tree is directly contiguous with the vast microvasculature of the liver. It essentially acts as an abscess under pressure, intimately intertwined with the systemic circulation. And that is exactly why early mechanical drainage is mandatory, rather than just relying on medical management alone. Under normal physiological conditions, the biliary system is well protected by 3 primary defenses. First, you have the continuous unidirectional flow of bile, which physically flushes translocating bacteria right out into the duodenum. Second, the chemical composition of bile salts has an inherent antibacterial effect against gut flora. And third, the structural integrity of the sphincter of Oddi mechanically blocks the retrograde ascent of any duodenal organisms. But when a physical obstruction occurs, all 3 of these robust defenses are simultaneously compromised. In this setting of absolute stasis, gut organisms, typically gram-negative enterics like E. coli and Klebsiella, multiply wildly in that trapped, stagnant bile. What's really fascinating here is that the critical variable driving his systemic collapse is entirely mechanical. It's all about intraductal pressure. A normal, common bile duct operates dynamically at roughly 10 centimeters of water pressure. Down at this physiologic level, the mucosal barrier, specifically those tight junctions linking adjacent cholangiocytes, remains structurally intact and impenetrable to bacteria. However, the liver is a high-volume secretory organ. It keeps producing between half a liter and a full liter of bile per day, completely regardless of the distal blockage. So as the liver pumps all this fluid into a strictly closed system, the intraductal pressure climbs incredibly fast. Once that pressure pushes past 20 centimeters of water, the mechanical stress is simply too much. The tight junctions between the ductule cells rupture and give way. And that structural failure of the tight junctions immediately opens up two high-flow pathways for retrograde infection. The first is cholangiovenous reflux. This is where bacteria and inflammatory endotoxins are pushed backward under high hydrostatic pressure directly into the hepatic sinusoids and then the hepatic veins. The second pathway is cholangiolymphatic reflux, where the contents just overflow into the periductal lymphatics, eventually draining right into the thoracic duct. Both of these pathological routes land massive inoculums of bacteria directly into the systemic circulation in a matter of hours. This specific physiological shunting is exactly why our patient experienced violently shaking rigors overnight, why his peripheral blood cultures are undoubtedly going to return positive, and why his clinical status crashed so precipitously. As clinicians, our physical exam has to be highly attuned to these progressive signs of decompensation. The classic presentation, as we know, is the Charcot Triad: right upper quadrant pain, clinically apparent jaundice, and fever. While our patient initially presented with those three, his evolution today into new confusion and a hypotensive state means he's transitioned into the Reynolds Pentad. We have to view the Reynolds Pentad not just as the addition of two severe symptoms, but as the objective clinical manifestation of overwhelming endotoxemia driving true multi-system organ failure. Specifically, we're looking at acute cardiovascular collapse and toxic metabolic encephalopathy. But we have to maintain a really high index of suspicion because a significant portion of our patient population will completely fail to mount this classic inflammatory response. In older patients, or individuals with poorly controlled diabetes like our gentleman, or those on chronic systemic steroids, or even advanced chronic kidney disease, the systemic immune cascade is heavily blunted. For these vulnerable cohorts, the absolute only physical findings might be an unexplained fall at home, acute delirium, or isolated silent hypotension. The literature actually shows that the classic Charcot Triad is only present in roughly 70% of true cholangitis cases. So while its presence aggressively rules the diagnosis in, its absence must never rule the diagnosis out. When we evaluate the underlying etiology of the obstruction that's driving this cascade, we have to commit to the statistical probabilities. 85% of the time, this entire sequence is initiated by cholelithiasis, just a simple, benign, common bile duct stone. Given our patient's documented history of cholelithiasis 2 years prior, his acute presentation is overwhelmingly consistent with a stone migrating into and lodging right within the distal common bile duct. To formalize our clinical assessment, we use the Tokyo guidelines, specifically the TG18 criteria, to definitively diagnose and grade the disease. These criteria are divided into 3 distinct domains. Domain A requires evidence of systemic inflammation, like a documented fever or a markedly elevated white blood cell count. Domain B demands evidence of cholestasis, which presents as clinically obvious jaundice or significantly abnormal laboratory markers, like elevated bilirubin and alkaline phosphatase. Domain C necessitates imaging confirmation, showing either a dilated biliary tree or a direct visualization of the obstructing cause. A patient presenting with A alongside either B or C is considered a suspected case. But a patient exhibiting A, B, and C simultaneously yields a definite confirmed diagnosis of acute cholangitis. Our 68-year-old gentleman unquestionably fulfills all 3 of those domains. His fever of 39.2 degrees Celsius fulfills domain A. His bilirubin of 6.8 fulfills domain B, and the bedside ultrasound revealing an 11 millimeter dilated common bile duct with a visible distal stone fulfills domain C. Clinically, a markedly dilated duct in a highly septic patient is fully actionable. We don't need, and frankly, we shouldn't delay care to obtain an MRCP or an abdominal CT scan. The diagnosis is absolute, and any delay for advanced imaging simply wastes critical time while the patient remains floridly bacteremic. Now that the diagnosis is confirmed, we turn our attention to the timing of mechanical intervention. This is entirely dictated by the Tokyo severity grading. Grade 1 is considered mild disease, which allows for supportive care, antibiotics, and watchful, elective drainage if they fail to respond within a day. Grade 2 is moderate disease, requiring early intervention within hours. To meet Grade 2 criteria, a patient must possess any 2 of the following: an abnormal white cell count, a high fever of 39 degrees Celsius or higher, an age of 75 years or older, a total bilirubin of 5 milligrams per deciliter or more, or a critically low albumin. Our patient arrived with a high fever, an elevated white count, and a bilirubin well above 5, satisfying 3 criteria for Grade 2 right upon arrival. Grade 3 indicates severe disease, defined absolutely by the presence of dysfunction in any one organ system. This includes a vasopressor-dependent blood pressure, disturbed consciousness, a creatinine climbing above 2, or a platelet count falling under 100,000. We have to carefully analyze his clinical timeline to understand his current severity. He arrived meeting criteria for grade 2, but our resuscitation efforts over the last 4 hours have proven inadequate. Despite administering 2 liters of aggressive crystalloid fluids, his blood pressure has plummeted to 78/44. He is newly confused, requires norepinephrine to maintain perfusion, and his serum lactate has acutely climbed to 4.6. This unmasks the full Reynolds Pentad. He has now escalated into a grade 3 emergency with multi-organ failure. He failed his initial ward management not because our chosen antibiotic coverage was incorrect, but simply because the biliary duct remains mechanically shut. This rapid failure emphasizes a fundamental pharmacokinetics teaching pearl regarding biliary infections. You can sterilize the blood significantly faster than you can sterilize the duct. The excretion of circulating systemic antibiotics into the biliary tree is an active transport process, and it fundamentally relies on continuous flow. Because our patient's duct is obstructed, drug concentrations within that stagnant infected bile remain entirely subtherapeutic, regardless of how exceptionally broad our intravenous antibiotic coverage is. The high pressure gradient just keeps actively seeding the bloodstream with endotoxins. If a patient's fever breaks shortly after the first dose of antibiotics, it's actually a false reassurance. It only signifies that the transient bacteremia was cleared. The primary source remains untouched, and the patient will inevitably relapse into sepsis unless the duct is physically opened. Recognizing his rapid transition into a grade 3 crisis, we're executing the strict first-hour protocol. We immediately draw aerobic and anaerobic blood cultures, followed by initiating broad-spectrum antibiotics within the first 60 minutes. Crucially, we do not delay this step to wait for any further imaging. We administer 30 milliliters per kilogram of crystalloid fluids, utilize norepinephrine to counteract his profound vasoplegia, and aggressively correct any underlying coagulopathy, since safe endoscopic intervention requires normalized clotting function. Most importantly, we call the advanced endoscopist now. We're utilizing antibiotics like piperacillin tazobactam, and ensuring we add targeted enterococcal coverage since the duct will be instrumented. Our entire medical management strategy rests on a single axiom. We resuscitate in order to drain the duct, not instead of draining the duct. Furthermore, this antibiotic regimen will run for a strictly limited duration of 4 to 7 days, counting only from the exact moment complete source control is achieved. As we plan his definitive procedure, we always keep the 80-20 rule in mind. Statistically, about 80% of cholangitis patients will clinically settle with high-quality intravenous antibiotics and can safely undergo elective drainage the following morning. Our patient, however, falls squarely into the critical 20% who do not respond. The clinical markers identifying this failing 20% are unambiguous. They remain persistently febrile after a day of treatment. They are utterly unresponsive to aggressive fluid challenges. They become dependent on vasopressors. They demonstrate altered mentation, or they exhibit a rising lactate. Treating a patient with grade 3 severity as if they were a stable grade 1 is exactly how preventable mortalities occur in this disease state. The immediate definitive therapy here is an ERCP. The endoscopist will first cannulate the ampulla of water. The second step, the endoscopic sphincterotomy, is the ultimate life-saving therapeutic event. By selectively cutting the sphincter muscle, they immediately release the entrapped pus and infected bile that's currently held under massive pressure. This intervention is physiologically identical to broadly incising a subcutaneous abscess. Following decompression, the endoscopist clears the tract by extracting the stone using a specialized balloon or basket. And finally, they insert a plastic biliary stent to guarantee continuous, unimpeded ductal drainage in the postoperative period. The exact moment that sphincterotomy is performed, the underlying pathophysiology rapidly reverses. Post-drainage, the intraductal pressure instantly drops from that pathological high of above 20 centimeters of water right back down to the normal resting baseline of 10. As the pressure falls below the threshold of the tight junctions, the deadly cholangiovenous and cholangiolymphatic reflux into the systemic circulation abruptly stops. With the mechanical flow restored, our intravenous antibiotics can finally be actively excreted into the bile to clear the localized residual infection. We routinely observe that the patient's fever breaks, their shock resolves, and their hemodynamics stabilize remarkably fast following decompression. To wrap up this case presentation, we should contextualize this disease against some important contrast cases and key clinical pearls. First, always consider obstruction by malignant tumor rather than a benign stone, specifically cholangiocarcinoma, pancreatic head cancer, or an ampullary tumor.
These patients typically present with profound, painless jaundice long before they ever mount a fever. But once that malignant stricture becomes infected, the physiologic cascade into sepsis is entirely identical to our patient's course today. The critical management difference is that a tissue biopsy is taken during the ERCP, and the procedural plan often involves placing a palliative stent or preparing for surgical resection. Second, remember the patient who hides the diagnosis. In older or diabetic demographics, the only finding may be confusion, a fall, or isolated hypotension. That is exactly why the triad, which is present in only 70% of cases, rules the disease in, but its absence never rules it out. Finally, a few cardinal pearls to remember on the ward. A dilated duct in a highly septic patient is sufficient evidence to act upon immediately. Remember that a fever breaking after the first dose of antibiotics merely indicates the bacteremia was temporarily suppressed. It absolutely does not mean the duct is clear. Be highly vigilant of the patient with an old, indwelling biliary stent, as these can occlude entirely silently and present later as devastating sepsis without any accompanying abdominal pain whatsoever. And ultimately, for our patient today, once source control is achieved and he recovers from this septic insult, the gallbladder remains the origin of the stone and will still need to come out later in the admission. Thank you, Dr. Smith.